Hello everyone, welcome back to my channel. Today we are continuing our liver series and the topic of discussion is liver cirrhosis. So in this video we will break down the key concepts, the imaging features and important points you should know, especially from a radiology perspective. So stay tuned and let's get started. So liver cirrhosis is actually the end stage disease, the clinical and the pathologic result of chronic liver injury. Okay, there is hepatocellular necrosis and there is chronic liver injury. It produces extensive fibrosis and nodular regeneration in the hepatic parenchyma at the same time, thus replacing the liver, replacing the normal liver parenchyma and resulting into chronic liver disease, the hepatocellular necrosis. It is a multifactorial in etiology and the causes include, of course, the most common cause, the alcoholic. Other are like viral hepatitis, then biliary disease, for example primary sclerosing cholangitis, then the metabolic diseases, for example Wilson's disease, then autoimmune diseases, autoimmune hepatitis, some vascular causes like congestive hepatopathy, Buercher syndrome and so on. Another very important cause is NAFLD, that is non-alcoholic fatty liver disease. Okay, so let's now discuss the imaging features of liver cirrhosis. So the imaging features are due to two causes. Okay, one is the morphological, that is due to liver itself, and another are due to portal hypertension. They are related to the effects of portal hypertension. We will learn these imaging features on ultrasound, on CT, and we will look the MR feature of nodules and HCC in the next video. Okay, so let's first see the morphological findings in liver itself because of the chronic fibrosis and nodular regeneration that is happening in the liver parenchyma. Okay, so there is this surface nodularity. Okay, see, the surface of the liver is nodular, there is surface nodularity. The liver parenchyma become very coarse, heterogeneous. Okay, there are multiple regenerative nodules. As I have already told, fibrosis plus regeneration goes both at the same time, so there are multiple regenerative nodules. There is a volume redistribution, like in form of hypertrophy of the caudate lobe, hypertrophy of the left lobe and relative atrophy of the right lobe. Okay, there is widening of the fissures and periportal pericholecystic spaces. The parenchyma become coarse. Okay, so why these changes are happening? Okay, so the morphological changes of liver, the main cause is fibrosis and nodular regeneration. Okay, so why this volume redistribution, why the right lobe is getting atrophied and the caudate and left lobe is getting hypertrophied? um, because the right lobe of the liver, this is right lobe, this is left lobe, this is right lobe of right branch of portal vein, this is left branch of portal vein. So the right lobe of liver gets its blood supply mainly from the right portal vein, which is getting blood supply from the SMV, and SMV drains the upper part of GI tract, which carries more toxins, for example alcohol. So right lobe is affected more, it gets more like sort of more atrophy, but the left lobe and the caudate lobe is mainly supplied by this left branch of portal vein, which gets its majority blood supply from the IMV and which drains the inferior gut, okay, which has lesser toxins as compared to the upper GI tract. So that's why there is this volume redistribution, as I've already told in my first video of liver segmental anatomy, why the caudate lobe gets hypertrophied in cirrhosis, because of the different blood supply it has. Okay. Another thing, there is this notch sign, the right posterior hepatic notch sign. There is this concavity at the posterior segments, along the right border of the liver. It is more prominent in cases of alcoholic than cases of viral hepatitis, because this happens because of the relative hypertrophy of this caudate lobe and atrophy of the right lobe. There is this notch appearance called as right posterior hepatic notch sign. Okay. So the liver become coarse, there is volume redistribution, there is widening of the fissures and spaces, there is this notch sign, and there are nodules. Okay, we'll discuss this nodules later in our videos in very much detail. Okay, so the next thing is, these are the changes of morphological changes in liver. Next is the changes due to portal hypertension. Okay. So first of all, the question is why there is portal hypertension, because this is the liver, this is the portal vein. Portal vein carries blood from towards the liver from the GI tract. Okay, but when this liver become coarse, the pressure between the liver increases and thus portal vein cannot take its blood in this direction. Instead, it becomes hepatofugal away from the liver. Okay, there is very high pressure and portal venous blood cannot be drained into liver. So the flow is no more hepatopetal, but it's become hepatofugal. Okay, so in order to compensate for all these changes, these veins dilate. Okay, the portal vein diameter cutoff is 13 mm, for the splenic vein it is 10 mm, and for the SMV it is 12 mm. So these veins diameter increases. Okay, there is splenomegaly with gamma Gandhi bodies. These gamma Gandhi bodies are actually tiny echogenic foci within the splenic parenchyma because of the sidrotic deposits within them, and other causal we'll see. There is this splenic interface sign we will see later on. So due to this portal hypertension, diameters increase, there is a splenomegaly with gamma Gandhi bodies and splenic interface sign. There are development of collaterals and varices because the flow is no more hepatopetal but it becomes hepatofugal. So to drain this blood, the portosystemic collaterals now open and their flow become reversed. Okay, next is the ascites. Then there is this bowel wall edema, especially of the large bowel loops known as portal colopathy. There is GB wall edema, the reactive GB wall edema. All these changes in liver cirrhosis are due to portal hypertension. Okay, so now we know why there is hepatofugal flow, because the pressure, there is so much of pressure. We will look at the Doppler parameters also, but before that let's see the portosystemic collaterals. Okay, so see, um, okay, the image credit here goes to the Radiogyan. You can read that read this article there also. So these are the portal and systemic drainages having communication at various sites. So see, the direction there is this, every direction is like hepatopetal, but when the direction reverses, there is hepatofugal, then these channels open and there is development of this collaterals and varices and shunts. These are the main sites for systemic collateral pathways, and the main collaterals that we see on CT and ultrasound images are this esophageal, paraesophageal, perisplenic, then this retrogastric, paraumbilical, anti-abdominal wall, varices, mesenteric, and the hemorrhoids. Okay, just know about these various sites for portosystemic collateral pathways. Okay. Okay, so let's see. The normal flow in the portal vein is hepatopetal. Okay, the normal flow in the hepatic vein is triphasic. Artery, it is like peak velocity is up to 100, and in portal vein there is general undulations. But when the portal vein flow is reverse, there is hepatofugal flow, the portal vein becomes dilated. The portal vein spectra is like, there is presence of hepatofugal flow, there is sometimes there is absence of flow, there is reversal of flow, there is loss of this general undulations, and of course reduced PSV. In as the portal vein blood supply is reduced, hepatic artery is like dilated and become hypertrophied and tortuous. So the hepatic artery trace here, the peak velocity increases. Okay, increased velocities are there with aliasing flow, and hepatic vein flow becomes monophasic, dampened from this triphasic flow, because as the liver is cirrhotic, there are multiple nodules, and these nodules actually causes pressure on the hepatic veins, thus their flow is very limited, and thus the flow becomes monophasic from the triphasic pattern. Okay, there are, as I have said, there are multiple collaterals like the splenic collaterals, the linorenal means between the kidney and the spleen, then the splenoperitoneal collaterals. The direction of flow in the portal vein reverses, so is the direction of blood in the splenic vein. There are collaterals in the gastroesophageal region, the perirectal region. There are varices along the gallbladder wall, there are varices along the omental region beneath the anti-abdominal wall. The flow of the left gastric vein, also known as the coronary vein, also gets reversed. Left coronary vein also becomes dilated in its diameter. There is a recanalization of the paraumbilical vein, there is appearance of this caput medusa along the umbilicus. All this is because of the opening of the portosystemic collaterals, the portosystemic shunts. Okay, paraumbilical vein recanalization is a very specific feature for cirrhosis. Okay, so these are the collaterals. Now let's look at the ultrasound findings for liver cirrhosis. So there is surface nodularity, the echotexture is coarse, there are multiple regenerative nodules, there is caudate lobe hypertrophy, there is poor visualization of hepatic veins because of their compression via the nodules, there is splenomegaly, there are gamma candy bodies within the splenic parenchyma, there is splenic interface sign, that is linear hyperreactive channels in the splenic parenchyma. There is increase in the bowel wall thickness, there is gallbladder wall edema. Okay, these are all the these are all the findings due to both the morphological and portal hypertension. And amongst the Doppler findings, the portal vein diameter becomes increased like more than 13 mm. The peak velocity decreases like less than 12 centimeter per second. The respiratory variability is lost. Direction of flow becomes hepatofugal. Okay, the diameter of splenic vein is more than 10 mm, superior mesenteric vein is more than 12 mm, hepatic vein flow is also dampened, hepatic artery PSV increases. So these are all are the Doppler findings of liver cirrhosis. This is all about USG. Okay, the same findings are seen in CT also. The nodular surface margin, the splenomegaly, ascites, collaterals, varices, all these are very well seen on CT also. One thing that is caudate lobe hypertrophy. This can be measured also via this caudate to right lobe ratio. Now, how to calculate this? We have to draw two lines. Okay, line 1 is drawn along the right border of the bifurcation of right portal vein. Line 2 is drawn along the medial border of the caudate lobe. Okay, and one horizontal line is drawn perpendicular to these lines, and that is midway between this main portal vein and the IVC, and this difference is caudate lobe, this is right lobe, and so caudate to right lobe ratio is measured. More than 0.65 is likely to be cirrhosis, and more than 0.73 is very likely to be cirrhosis. Okay, so just know these lines and calculate the caudate to right lobe ratio. So as discussed earlier, all the findings that we have discussed are very well visible on CT also. Left renal vein can also be very well seen, that is also enlarged in cases of CLD. And next, all the collaterals can be very well seen, the paraumbilical vein recanalization, caput medusa, the paraesophageal collaterals, sphenorenal collaterals, the varices and all. Okay, so these are actually the imaging findings of liver cirrhosis, including both the liver morphology and the things due to portal hypertension. In next video, we will discuss about the nodules of liver cirrhosis, the regenerative nodules, dysplastic nodules, and finally we will discuss the much awaited topic, that's hepatocellular carcinoma. So for the time being, let's end it here only. We'll catch you up in the next video. Thank you.